Okay, thanks very much. So, end of the long day. If you're not off in the crowd, I won't be offended, I promise. So, I think it's an opportunity, Antimicrobial Awareness Week, to address antibiotic allergy. So I'm going to give you sort of a bit of a roadmap through how it affects our prescribing and some practical approaches that we're taking at the hospitals I work at, Austin and Peter Mac. So, as mentioned, Antibiotic Awareness Week, and I see many adverse drug reaction stickers on patients' records, and reacted to all antibiotics is something, unfortunately, that we do see in clinical practice, and it leads to a lot of this just picking random antibiotics that aren't on the list, often irrespective of what the clinical indication is or how effective it might be. And it's led a lot of authors to try and suggest that antibiotic allergy should be incorporated into our antimicrobial stewardship programs. And a number of actually interesting innovations, predominantly that have come from overseas, trying to incorporate the two and combine allergy and AMS and ID. So if you look at the hard numbers, patient-reported penicillin allergy is about 9 to 12% in hospitalised patients, and probably close to that in community practices where the group is older. Penicillin allergy labels are associated with poor prescribing, excess lengths of stay, antimicrobial resistance, and interestingly, in a recent publication, surgical site infections. And it's disappointing because many people are labelled as allergic, but very few are actually allergic when you come to test them. I use this picture a lot. There's actually a real patient who labelled themselves allergic but was negative on testing. So I thought, to try and avoid this queue and to give myself a job, I would create antibiotic allergy within AMS. And wrote a paper, of course, to say that we should do it. And then the guidelines from the USA came out suggesting, yes, allergy assessment might be a good idea, but how about showing us some evidence? So we've gone some way to try and prove that antibiotic allergy affects prescribing, and that when you do address it, you improve outcomes. So I'm going to try and show you that, yes, there's a need and the role is there. So this was data that was kindly done with NAPS and NCAS and Professor Thursky, where we took the NAPS data from 21,000 patients at that point in time and looked at our national inpatient allergy label prevalence. And the prevalence was about 18% and 9% for penicillin, similar to that historical mark that we'd seen reported elsewhere. The interesting finding was that the prevalence was much higher in our big users of antibiotics, solid organ transplant, respiratory units, hem-onc. So I think certainly they're been the key targets of most of our interventions that have the highest allergy label prevalence. And when you look at the impact on prescribing, you can see there is a marginal increase in inappropriate prescriptions in those with an antibiotic allergy. But if you look above that, the predominant effect are those that are immunocompromised. So a lot of our work has therefore been to address these groups with the larger disparity in inappropriate prescribing. And we thought, okay, it's impacts on prescribing. Well, if we start a service, will anybody actually use it? So we surveyed a group of ID physicians, allergists, immunologists, and pharmacists in Australia, and also did a similar survey of ID physicians in the US. And actually, interestingly, most people in those communities felt that antibiotic allergy programs would aid prescribing practices and certainly a number of AMS endpoints. But the disappointing thing was that only 43% had testing available to them in Australia, and a little bit better in the US. So I think I want to try and show for the next bit that antibiotic allergy programs are central to the 4 Ds of AMS. And it's certainly all about recognising dose-dependent adverse drug reactions, vancomycin with red man syndrome, quinolones, which actually can cause urticaria with anti-true allergy. It's all about reducing duration of antibiotic course length. I think we can increase narrow-spectrum beta-lactams, particularly for conditions where we want to use them. And I think also it will help with de-escalation. Clinicians are very comfortable de-escalating to an antibiotic they know, like amoxicillin. And if we can give that back to clinicians, I think that'll help that IV to oral switch. And not to mention impacting or reducing the use of clindamycin and fluoroquinolones in these patients. So antibiotic allergy has been merged with AMS, and some data has shown that yes, it helps certainly in MSSA infections. Pharmacist-led referrals directly from dispensing to allergy clinic also increased beta-lactam uptake, and some small studies done in acute care settings also demonstrated similar findings. There's certainly been some cost-saving benefits with penicillin allergy testing. I think that's hard in our climate when ceftriaxone costs 90 cents and benpen costs a lot more than that. And ID fellow and pharmacist-led programs in the US have also proven successful. But if you look at it in a pragmatic fashion, they're mainly being used in very low-risk patient populations in the US, people that probably we should just re-challenge. And there's lots of implementation barriers. It's not just a matter of setting up a clinic, it's resource-rich, using a non-TGA approved reagent, there's specialist knowledge required, and also what do you do about non-penicillin allergies when it's clindamycin or fluoroquinolone or vancomycin or ceftriaxone? So those things require a bit more complexity rather than just delabeling the penicillin allergy in the 1940s. So how can we reduce the impact of antibiotic allergy? What are some practical solutions? And what is the role of multi-disciplinary antibiotic allergy testing? So the first thing is cross-reactivity, and I think simply explaining this to healthcare workers is the first point that we can improve prescribing. So I was taught at medical school if you're allergic to the beta-lactam ring, you're pretty much allergic to all beta-lactams, even though the cephalosporins have a different side chain and a different R1 side chain over here, and also beta-lactams, even simple penicillins have different R1 side chains. And I was told that cross-reactivity was 10% between penicillins and cephalosporins. Where in good modern data that's wrong, it's less than 2% for cephalosporins, less than 1% for carbapenems, and 0% for monobactams or aztreonam, a forgotten antibiotic. So the rates of cross-reactivity are a lot less. And if you map out all these particular side chains, and you say compare penicillin to Keflex, you can kind of get an idea of what's more likely to cross-react. And we did this in a recent publication. It was painstaking. And the most common thing is that amoxicillin shares a side chain with Keflex. And Keflex shares one with C-chlor. And it happens in practice. So this patient came in, had Keflex urticaria. We skin tested and they were positive to ampicillin. So it also works the other way. We want to delabel patients. This also gives us an opportunity to say, hey, I should avoid that antibiotic in somebody with a Keflex allergy because they're likely to react based upon their side chain. So the beta-lactam cross-reactivity is really an important practice. So some more proof of practice. This is a tazocin patient, tazocin allergy anaphylaxis at Peter Mac, and tolerated penicillin V, Keflex and amoxicillin. This is a cefazolin anaphylaxis patient who reacted to cefazolin on the skin, but again tolerated penicillin V, amoxicillin and Keflex. This is done in a controlled environment, but the cefazolin story is very interesting. Trish pointed out the most commonly used antibiotic in surgical prophylaxis, rising rates of anaphylaxis, but it seems to be a very isolated allergy just to their particular R1 side chain. So an evolving landscape with cefazolin. And many amoxicillin skin test positives will tolerate other penicillins. So I think this knowledge, you don't need an allergy testing program. You can incorporate this into your local clinical guidelines. So for example, here's our revised surgical antibiotic prophylaxis chart that's going to go up in all the theatres. We've made a big emphasis on including a beta-lactam allergy box to try and put people back onto cefazolin therapy. And this guideline's been based upon, the Epworth guideline. If anybody's seen that, it's beautiful. We can never get it to look as nice as that. But I think certainly we can include beta-lactam allergy work in that guideline. And the other thing is haematology. Can we pre-plan febrile neutropenia? Have a look at their allergy label, work out if it's real or false, and then decide if it's tazocin or cefepime rather than Cipro and Vanc or a carbapenem. Okay, so what about antibiotic allergy testing? And I think there's three things. There's direct delabeling, there's penicillin oral challenge, and then there's a centralized testing process. And I think the direct delabeling is the easiest. So this was some work we did at the Alfred. We looked at using NAPS data again, but the Alfred collected information on the types of antibiotic allergy. We found that by far and away beta-lactams predominated, which wasn't a surprise. But if you look at the types of allergies, type A adverse drug reactions made up almost 20% of reported allergies, and 21% nobody had bothered to ask what it was. So more than likely a very large proportion are just rubbish from the outset. So I think this should be removed, these type A allergies should be removed from the drug chart by the pharmacist. A clear history of type A adverse reaction of diarrhea, nothing else, it should be removed. We can all do that. What about direct oral penicillin re-challenge? Well, there's a growing support or growing evidence that many penicillin allergies that are remote or historical in nature and low risk can be re-challenged by ID teams. And there's some nice data coming out, again, out of the US. We looked at our elderly group of general medical patients and found that 63% would be what I would consider low risk, and 48%, when you go and ask them, are very happy to be re-challenged. So protocolized re-challenge has been performed in the US, mainly out of Boston with good success, and these two recent papers demonstrated again very low rates of reproducible allergy. One of them was an interesting paper in San Diego at a naval base They said, oh, bugger the skin testing, we're just going to challenge all these Navy recruits. And even people with urticaria or good-going allergies, the reproducible reaction rate was 1.5%. I don't think we should go and re-challenge those group of people, but certainly the low-risk patients, a type A adverse reaction, a mild childhood exanthem that's likely viral in nature, are a group that we could consider re-challenge in a supervised environment. So we've gone about producing an oral re-challenge penicillin guideline that has strict oversight by the ID department and pharmacy team, again based upon this key criteria, and this has been rolled out at the Austin and Peter Mac. I think this is something that many patients in many hospitals could adopt even without a strong allergy service or skin testing procedures. So the last thing I'm going to focus on is centralised antibiotic allergy testing. And as I mentioned, there are certainly barriers to setting this up and logistical things that I found from the outset. But we started up these centralised testing services based upon that stakeholder knowledge, and the programs are based upon some great work done by Professor Elizabeth Phillips in WA. And the delabelling process is really based upon three things. And it's based upon that cross-reactivity knowledge, it's based upon the fact that many allergies are lost over time, and it's also based upon the very high negative predicted value of penicillin skin testing. So we set up this service at the two sites, and we engaged really with ID, AMS, Allergy and pharmacy. And in fact, when I look at the referrals back across time, most of our referrals were generated from pharmacy and AMS, who are provoking the clinician or the ID team to refer onto the service. So pharmacy probably should be a huge box on this slide, to be honest. And when we look at the impacts of this practice and the before and after study, you can see that we had an increase in narrow spectrum penicillin, narrow spectrum beta-lactam, and beta-lactam, beta-lactamase inhibitor drugs, and a reduction in restricted antibiotics, even when we adjust for medical comorbidities, age, site of infection, and inpatient or outpatient status. So certainly this got some problems. It's a before and after study, but it's some evidence that such a centralised process can impact on prescribing. We were able to remove an allergy in 83% of patients, and we're able to increase antibiotic appropriateness using the NAP score in a significant fashion. So this is certainly potentially a way forward, and maybe needs to be a state-based service, generally due to the complexity of the testing. So here are my conclusions or roadmap to antibiotic allergy. I think everybody should assess their own antibiotic allergy label burden and their key target groups. I think we can easily integrate beta-lactam cross-reactivity into new and existing guidelines, be that febrile neutropenia, PJP prophylaxis. I haven't talked about sulfonamide allergy today, it's a whole other talk, and perioperative prophylaxis. We can examine the feasibility of direct delabeling in oral challenge programs, particularly that are pharmacist-led. And I think an AMS-led program with appropriate governance, particularly for oral rechallenge, is something that we could consider. We need to develop targeted antibiotic allergy testing for penicillin and antibiotic allergy label. And I think the centralised or state-based approach, particularly for the high-risk, complex patients and those with severe cutaneous adverse reactions like Stevens-Johnson syndrome, is probably the way forward. So thank you very much. I'm happy to take questions at the end or talk to me afterwards. There's a lot of people that were very helpful in starting this service, many of them sitting in the room. So thank you very much.